The Parkinson's podcast is brought to you by the Davis Phinney Foundation and brings you the stories, wisdom, and expertise of people living with Parkinson's, care partners, and Parkinson's professionals. Additionally, we would like to thank our title podcast sponsor, AbbVie, for helping us bring this content to you. AbbVie is committed to recognizing the uniqueness and needs of each person living with Parkinson's and delivering innovative solutions for patients, care partners, and clinicians. In this episode, Dr. Videnovic explains sleep attacks, REM sleep disorder, Restless Legs Syndrome, insomnia, daytime sleepiness, drowsiness, fatigue, as well as how you manage these, the importance of understanding and attending to your circadian biology, and using things like light and timing of exercise and medications to improve sleep.
Okay, so I'm really excited to welcome you here today. We're going to talk about sleep and light and neurodegeneration, and I would love to hear from you about what you're doing and how you got interested in sleep and movement disorders and where your sort of research and experience has brought you.
Good morning, everyone. It is really my great pleasure to be with you all today, and this is the first program that I'm doing with the Phinney Foundation. I'm very excited about that, and would like to applaud to all of your efforts and for bringing such a great PD community together. These are such a worthwhile and much needed efforts, and it is wonderful that I have this opportunity to be part of this today.
Yes, and I will say, I have to tell you this, because when I was putting this together and I was talking to our friends about sleep, you were at the top of every person's list. So I was like, well, how have we not had him on just up to this day? So I'm really thrilled to finally have you on with us.
Oh, this is very kind. There are many colleagues who do this line of work, and but this is very kind. Your comments are very kind. Just to briefly introduce myself, I'm a neurologist, I'm a movement disorder specialist, and also I specialize in sleep medicine. I work at Massachusetts General Hospital in Boston. Prior to my work at Mass General Hospital, I was in Chicago at Rush University Medical Center and subsequently at Northwestern. How did I develop interest, both clinical and research interest in sleep? Well, actually that dates back when I was a fellow in movement disorders from 2005 to 2007. And at that time, really a lot of my patients would come to see me and they would complain about excessive daytime sleepiness. It was a time when dopamine agonists, which many of patients who join us today, I'm sure, still using, are in the focus of medical and scientific PD community because of those associated issues of sleep attacks and sleepiness. And this was really very debilitating to my patients at that time. I developed the interest in that area, what can we do to help them, and everything else is in the past. I remain in that field of work with some additional aspects as well. But I really dedicated a lot of my both clinical and research work to the intersection of sleep and Parkinson's disease, and I'm sure we will have an opportunity to talk about this today during this interactive session.
Yeah, absolutely. Well, thank you so much. One of the things that I know that I want to give to our audience today is this ability to kind of be a fly on the wall in a conversation with a doctor. They very rarely, probably will never get 60 minutes with their doctor to talk about sleep, the one topic that can really impact absolutely every single area of their life. So I want to give them that today. So we'll get started on that. One of the things I want to start with, though, is just to for some people that are, maybe recently diagnosed with Parkinson's and they're hearing a lot of different things about, some people never sleep, some people sleep too much, some people have terrible dreams, some people don't. Love to just kind of start out with a level set and say, what is happening in the brain of somebody with Parkinson's that is impacting sleep? Why is this such a problem? And we know that it's a big sort of prodromal symptom, right? Why is that?
Well, the process that leads to eventual development of Parkinson's disease starts decades before the onset of first tremor or a balance problem or one arm doesn't moving much as we walk, right? So this is the process that starts 20, 30, 40 years before these symptoms emerge. And those changes in the brain are occurring very, very gradually. And these areas that are affected by these changes that are causative of Parkinson's disease do not necessarily start in the areas that are important for movement, right? Parkinson's disease is a movement disorder. Simply those areas can start in brain regions that are very relevant for the regulation of alertness and regulation of sleep. And as this pathology progresses, it will affect different regions of the brain in different patients. So therefore, the onset of sleep problems and the type of sleep problems that patients may develop throughout their journey with Parkinson's disease will be very different. And one aspect that we always share with our patients that there is no two Parkinson's patients that are fully alike and similar. And similarly, sleep problems are, we know, very ubiquitous in patients with Parkinson's disease, but may affect very differently our patients with Parkinson's disease. So changes in sleep are simply occurring in Parkinson's disease because they affect the areas of brain that are relevant for the regulation of sleep and alertness.
Great. So let's, I think it would be great. There are a lot of topics that everybody wants to talk about, and I want to make sure that we get to them. But let's start with one of the most common questions we get, which is, what is the difference between sleepiness and fatigue?
Yeah, that's a very good question. And the way I try to explain it is, fatigue is really a lack of energy, right? You just really feel very fatigued. You feel like you want to lay on the couch all day long. You're really exhausted if you try to get up and do some things, fix a lunch, go throw the garbage out, etc. Do any activities. You just feel exhausted, right? You just have a lack of energy. Being sleepy is a little bit a different phenomenon. And you just really have this urge to really fall asleep. You just need to close your eyes and you're just gonna easy drift to sleep. Even eating a lunch, breakfast or so, one can just nod off and fall asleep. With fatigue, however, one of the pointers that I like to tell my patients, if you are fatigued and if you lay on the couch, you will not necessarily fall asleep. You can feel exhausted, but even if you try to sleep, you may not be able to fall asleep. Sleepy person, they don't even need to lay down. They can fall asleep even sitting in a chair or at breakfast table. So I think this is how we can differentiate between these two phenomena, which can overlap, right? So both of these can coexist at the same time, but at the same time, they are different. They are really different aspects on a symptom spectrum, right? We are talking about very different symptoms. And in my experience, fatigue is much more challenging to address. Sleepiness can be very problematic as well, but there are things that we can think about what can be really the cause of that sleepiness and how we can intervene. With fatigue, which affects majority of our patients, at least almost all of them, if you look at the entire lifelong journey with Parkinson's disease, frequently it's a large unmet need. Frequently we can't do much to pinpoint the cause of it, and therefore we are not great as with treating it.
Right. And so sometimes when you are, well, we're going to talk about different ways to treat sleepiness and different sleep issues, but sometimes if you might very well figure out a way to get this person to sleep, and so they don't have the sleepiness, but they might still struggle with that fatigue during the day, and that's going to be a sort of different mechanism that you have to treat. Okay, so I know one of the fields that you're really very interested in and is circadian biology. Can you talk to us, what is circadian biology, and why do people with Parkinson's need to know about it?
Yes, Mel, this is an area of that we have really worked a lot on. And well, circadian biology is the area of biology that is interested in the study of our internal timing of what we call circadian system or circadian rhythms. Deep in our brain, we have about 20,000 nerve cells that function as our internal clock, our internal timer. All of us have it, right? And that internal timer that is located in the brain is the conductor for all other clocks that are distributed all over our body. All of our organs, our heart and kidneys and liver and stomach, they all have their own clocks. And this mechanism gives our organism the sense of time. And this central clock that is located in the brain coordinates the function of all of these other clocks across our body. And why do we need to have this timing system, this internal time, right? Well, we live on the Earth, and the Earth rotates around the sun. And as a result of that, we are exposed to dark and light cycles. And these dark and light cycles control our lives, right? They influence the social function and any other function for humanity. It is really that internal clock that signals our body and our organs and tells us, well, the dawn is just approaching, and let's synchronize our bodies so that we can get up, that we can have energy moving, and that the flow of food is appropriate, and the blood pressure goes up, and all of those things that are really very important for us to live on this 24-hour scale and to function as a humans during the daytime and during night. And this circadian system has been present and is present in all organisms on the planet. So it's evolutionary, very important biological phenomenon, right? When we talk about sleep, the rhythm and the circadian pacemaker is very important because it really helps times our behavior. It signals when we should go to bed. It helps us stay awake during the daytime, and it helps us stay asleep at night, where we shouldn't be asleep. The significance in Parkinson's disease is such that we and others have demonstrated that that clock is not ticking correctly in patients with Parkinson's disease. The strength of that clock and oscillations of that timekeeping signal seems to be dampened in patients with Parkinson's disease. And that can have a negative downstream effects on all of the other organ systems, which are really necessary for the appropriate functioning of of us, of humans, right? And the last piece that is important to understand, one can ask, well, this clock is deep in our brain, right? How does that clock know when is going to be the dawn and when the light is going to come out and when the dusk is coming, right? Well, the clock receives the signals from the outside world, and the most important signal is light, is sunlight. So that's the most important synchronizing agent, because that light from the environment and from the sun hits our eyes, and then special cells at the back of our eyes directly transmit that light. It's like a highway that goes from our retina, from our eye, directly to our circadian pacemaker. So light is very important, and we can talk more about that. How do we implement that in the daily lives of patients with Parkinson's disease? But even other activities that are non-photic stimuli, not related to light stimulation, can help synchronize that internal clock with the outside world. For example, physical activity can be great for telling for keeping our internal timer strong and on time. Even timing of meals throughout the daytime can serve as a good signal to our internal timing system to keep it function properly and work properly. So I hope that I brought this concept a little bit closer to the audience. I think this is a relatively novel research direction. I will leave it at this, and we'll see if we'll have more questions as the conversation evolves.
Yeah, absolutely. I know we'll come back to it, but just so that I understand, is it because is your meal timing and your exercise timing, how are those impacting your circadian clock? Is it because if you are getting it on a routine, you're teaching your clock, basically, like you're teaching your internal clock? And is it, well, if you exercise at the same time every day, or you have your meals at the same time every day, that's what's going to do it? But if you're all over the map, you're kind of going to mess your clock up a little bit.
Exactly.
Okay,
That is just right. Just think about traveling to the different time zone.
Mm-hmm.
When we go from East Coast, let's say we travel to India, it's going to be a huge shift. When we arrive to India, we're going to be reversing our biological daytime for the nighttime, and it's going to take a long time for the clock, who is not used to these cues from the environment, and it's not used to be awake at that time when it's supposed to be the nighttime in Boston, for example. It takes a long time, right? So think about those aspects, like a jet lag problem or issues with seasonal depression that can occur. Why does that happen? Because the lighting cycle from outside world is changed. Mm-hmm. And in the winter, the days are shorter. And that light that now does not get to stimulate that internal timing is reduced. And that can affect, for example, mood in this case. And we know that patients with Parkinson's disease frequently suffer from mood problems. So I think we have a really great opportunity to better understand the importance of that timing system for general health. This is relevant to all disciplines of human health, not only Parkinson's patients. But it's really important for our community of Parkinson's disease, first of all, because this is very dear to us. And there are potential interventions that we can employ to improve our function, really through using very easy non-pharmacological intervention without a lot of side effects.
Yeah, I think the interesting thing about this topic that's getting a lot more sort of prime time news these days, I think the interesting thing is probably for most of our lives, we've just thought, oh, well, it's just what it is. The clock is the clock, and it's light and it's dark, and there's nothing that we can really do. That's like That's bigger than we're able to do anything with. But what you're saying is, no, that's not true. And we have control. We have a lot of things actions that we can take, and hopefully we'll get into some of those specifically as we talk about treatments. So another question that we get a lot is, what can you say about the difference between sleep-related issues that are Parkinson's or age-related? Like, do they look different? And, a lot of people are saying, I don't know if it's just because I'm getting old or because I have Parkinson's.
That is a great question. And I would just say that there is a great overlap. Parkinson's disease is disease of aging. And all of us, as we age, will experience some issues with our sleep cycle. Our sleep is going to become a little bit more fragmented. Our deep sleep, which enhances memory formation, is going to be reduced as we age. But generally, aging population should still be able to achieve good sleep. Other things that are happening with aging and sleep is that comorbid sleep disorders start to occur in increase. And then if you have an aging, as we all hope to do, if everything goes well, if your aging gets complicated with Parkinson's disease, you have a double hit when it comes to your alertness during the daytime and nighttime sleep. And I would just look at Parkinson's issues as being much broader than normal aging, but superimposed on what normal aging does to sleep and sleepiness during the daytime.
Okay. A lot of times we'll hear, teenagers, they should be getting 10 hours of sleep. And, but that, as you get older, you need less and less sleep. And we think old people don't really sleep that much, or is that true also for people with Parkinson's, or is that absolutely not true? Like, everyone should be getting a certain amount, whether you have Parkinson's or whether you're 18 years old.
Well, we all need to get sleep, right? If we just don't get sleep, right, we simply would die, right? If somebody restricts your sleep, we would not survive. So sleep is really essential function for survival. Many studies have done to investigate how much sleep is needed and how much is enough. And we like to say that anywhere between 6 to 8 hours of sleep in general for the general population should be enough. Some studies have demonstrated that having less than 6 hours and more than 9 hours may have some negative consequences for health. For Parkinson's patients for decades, we have appreciated this phenomenon, which is known as sleep benefit. We hear over and over from our patients that their Parkinson's disease is not as problematic the day after a good night of sleep. And we hear that even responsiveness to some PD medications may be enhanced after a good night of sleep. And I believe there is a biological explanation for that, because dopamine metabolism, dopamine being one of the major brain chemicals involved in Parkinson's disease through being deficient in this disease state, metabolism of that dopamine may be dependent on how well is our sleep consolidated. So if we have a good physiological state of 5-6 hours of sleep, the majority of this is really uninterrupted and of a good quality. It may be that the dopamine availability may be enhanced, and therefore the following day, it can be a good day for us. So this is a phenomenon that is known and for decades, and something that many of our patients report. That's why we try to emphasize good night of sleep, especially in the Parkinson's disease population.
Great. Okay, so let's talk about different types of sleep disorders. And so daytime sleepiness, just want to go through a little bit of like, what does it look like? How does it show up for people? If they could say, oh, it's real sleepiness or drowsiness, sleep attacks, REM sleep behavior disorder, restless legs, insomnia, and then anything else you think we should talk about. So let's start in with the daytime sleepiness and drowsiness. What are people, what's happening to them, and what?
Sure. The patients really, it's simple, right? The patients will just doze off and will have to take many naps, and they are feeling very spaced out and go for a social event because they just feel that they cannot maintain fully their alertness. Frequently, though, patients will not be aware of it, so this is important to point. And if I have a caregiver or a spouse next to the patients, as I ask, how is your daytime? And they would say, great. And I see the caregiver nodding the head in a different direction. And patients are frequently not aware of them nodding off as they eat food at meal times, or how much they spend dozing off in a sofa or while watching TV or reading. Sleep attacks are a little bit more dramatic. Sleep attacks are these episodes where one transitions from full wakefulness to sleep very quickly. And that can happen even within 30 seconds. Sometimes patients do not even have warning signs of transitioning from full wakefulness to full sleep. And these are obviously very dangerous because there are situations where safety of the patient, their loved ones, or others on the road, if they are driving, may be in jeopardy. And this became very heated topic in the field in early 90s when the initial description of sleep attacks were reported in individuals who were taking and started to be treated with dopamine agonists like pramipexole and ropinirole. And these agents have up to 30% chance of causing excessive sleepiness and somewhat smaller percent of provoking sleep attacks. So that's why we counsel our patients when we start these drugs and monitor them on a regular basis after they have been treated with these medications, which are important medications to have in our doctor bag, but they can come with this potentially very troublesome side effect. So this is really what excessive sleepiness is. And the causes are really very numerous of this excessive sleepiness. And we can dive into those as well if you want. But in terms of the definitions of these two entities, this is what I would say about how we define sleepiness and sleep attacks.
Great. Yeah. So that note to care partners or friends or family members of people who are starting those drugs, definitely keeping an eye on that. Super important. Is there, in your research, have you found, is there, is it because people are not getting the sleep, or can they actually have a good night's sleep and then they're still facing this?
That's an excellent question. And it's this latter scenario. One would think, oh, this must be because I have a terrible sleep. And that can be true in some cases. Patients may have undiagnosed sleep apnea, waking up all night, not realizing that. And of course, they're going to be sleepy the following day. That's one of the cardinal symptoms of obstructive sleep apnea. But also patients may have a very good night of sleep and have a lot of challenges with staying awake during the daytime. That can be a result of certain brain areas that are important for controlling alertness when we are awake that are being affected by the disease, but also may be a result of maybe underlying depression and anxiety that are not being treated, or medications that are maybe causing drowsiness during the daytime. There are many possible explanations. So one home take message that I would have for everyone who is on this call today is we all should, including you, Mel, and myself, and we all should pause and ask ourselves, how is my sleep? how often do we think about that, right? How is my sleep? Is my alertness during the time good? Can I try to improve that? I bet you that a lot of us, if not the majority of us, really doesn't or hasn't asked this question recently. And this is really very, very critical. It's a similar question that we should ask for: how are my meals? How is my nutrition? Is my physical activity good? Do I keep connections with my friends and with my family? What is my social network? Because I heard someone said something recently which really struck me. He says, we want to go travel to the moon, and we don't know how to eat properly, and we don't know how to sleep well on the planet Earth, and we want to go to the moon. It's just really we have not capitalized on these important pillars of health, and only we are in control on these major pillars of health. And yet we have put too much effort on the chemistry and all of these pills, expecting that this chemistry that we put in our body needs to fix this. And sometimes we need pills, don't hear me wrong. But we'll be able to do so much better if we pay attention to these other aspects that are solely in our control. And right. So I went off tangent a little bit. You know, I'm on tangent here, but this is a really important message, right? This is maybe the most important message that I would have to relate to anyone who is on this call, including myself. I'm terrible for some of those aspects that I just mentioned. So I should take notes of what I'm saying today for my own purpose.
Right. Okay, so let's talk about RBD, REM Sleep Behavior Disorder. What is it? What does it look like? How does it show up for people?
This, well, we shouldn't supposed to have our favorite disorders, right? That's just a misnomer,
that seems wrong, right?
This is so important. This disorder is so critical. And let me explain why is it critical on so many levels. When we go to sleep, we oscillate through stages of sleep, and two major stages are REM sleep and non-REM sleep, right? And this disorder is called REM sleep behavior disorder. So this tells you that it's going to happen as we sleep, as we enter into that REM sleep, something is not right in this disorder, right? Well, what is not right is the fact that when we entered REM sleep, and if we have REM sleep behavior disorder, we are not paralyzed during that REM sleep. What I'm trying to say, normally, as we sleep and as we enter REM sleep, during that period of sleep, we cannot move. Our muscles are paralyzed. Only breathing muscles are working. And in this condition, REM behavior disorder, our muscles can move, right? Well, why would they move, right? If we are asleep, doesn't make sense. Why is that important, Dr. V, if muscles can move and if we sleep? Well, it's important because there is a second part, second side of the coin of that disorder, and that is that in REM sleep, we usually dream. Dreams are associated with REM sleep. And in this disorder, for unknown reason, there are action-packed, very aggressive, frightening dreams that are occurring. Somebody is going to attack us, or we just really want to escape the fire, or not even aggressive dreams. We just want to jump into the pool. We are sitting, standing at the edge of the swimming pool. And now you can act out your dreams, because remember, you are not paralyzed as you move to this sleep in this disorder. And as a result of that, if you are dreaming that you are ready to jump in a swimming pool, you will jump out of a bed on the hardwood floor of your bedroom. Or if you try to defend yourself, you're going to punch your bed partner, or you're going to choke your pet that sleeps next to you. So the disease is very important because it can cause substantial injuries and sleep interruption both to the patient and to the bed partner. And it is also important because we know that individuals who only have that sleep disorder are at increasing risk of developing Parkinson's disease or other Parkinson's related conditions down the road. So it's important to improve and treat this disease so we can minimize the impact on sleep and safety of our patients. But the disease has become so important that these individuals who only have these sleep disorders will now become ideal target population to study interventions aimed to slow the progression of Parkinson's disease, because it may take decades between the onset of these weird dreams and behaviors at night until the signs of Parkinson's disease show up. So we have an unprecedented opportunity as these new disease-modifying therapies become available to intervene earlier, have a chance at an earlier stage of neurodegeneration to be more successful in arresting that process. So this is what RBD is.
Right. So when let's say you actually get a patient who has RBD or comes to you and says, I'm having these issues with sleeping and I'm acting things out. There's no other Parkinson's related anything. They haven't been given a Parkinson's diagnosis, but you see them having REM sleep behavior disorder. Is there anything that you can do now? Like, what is it? Are you doing anything that is not, exercise, like anything that's pharmacological that you can actually do for those people now? Because I once heard a doctor tell me it was 100% that the people who have RBD actually is. How far off is that? That seems I've never heard 100% before with anything.
Yeah. Well, you should have not heard 100% because it is not 100%, and the numbers are very variable.
That's excellent.
The treatment question first. We need to treat the symptoms to minimize the chance for injury.
Mm-hmm.
In terms of preventing the risk of developing neurodegeneration, we have increasing number of longitudinal research projects and consortia, including RBD consortia, where we can enroll patients and do a yearly detailed assessments so that we can track eventual progression of their disease and get them ready for these disease-modifying trials. And one intervention that we will propose to these patients who have even only RBD is a vigorous exercise regimen. I know that you'll hear later on from my dear colleague and an expert in the field, Dr. Amara, about importance of exercise when it comes to sleep and other aspects of Parkinson's disease. But we know that the exercise from many studies may be enhancing health of these nerve cells that are producing dopamine. And while we can't tell them this is for sure going to be helping, we can say that there is excellent rationale for you to engage in a vigorous exercise program in order to reduce the chance of developing one of these disorders down the road. We hope to have interventions that are going to be soon launched that are going to be focused on prevention of development of these or progression of these neurodegenerative diseases in the RBD population per se.
Okay, great. Well, so we talked about acting them out. Is sleep talking, somebody asked, is sleep talking related to this? Is it part of?
Yeah, not necessarily. So the important message here at this point is to say that not everything that looks and sounds like RBD is RBD. Right, because we can't alarm the public because everybody is going to once or twice in life have something maybe similar to this, what I just described.
Mm-hmm.
For example, sleepwalking or isolated sleep talking are completely different phenomena from REM behavior disorder. Patients with RBD usually do not leave bed. They do not walk around the house. There may be overlap with sleepwalking and REM behavior disorder. So that's why it's important that if one has any suspicion or concern that this may be REM behavior disorder, that you reach out to your provider, you find a sleep specialist knowledgeable in this area. so that you can settle this issue. Because a really important message is not everything that sounds, that looks like RBD is RBD.
Okay. Is sleepwalking and sleep talking a thing that people with Parkinson's experience more than the general population, or is that not tend to be?
We do not encounter that frequently.
Okay.
Sleep talking maybe, but sleepwalking is mainly disease of our children and early and adolescents to a certain extent. We try to overgrow this problem as we age.
Okay. Okay. Can we talk a little bit about restless leg syndrome?
Another sleep disorder, and this disorder is classified as a movement disorder of sleep. And that is a condition usually which starts to creep up in the evening hours as one is relaxed and sitting on a couch watching TV or reading. And then there is this irresistible urge in legs, usually, sometimes arms as well, that urges us to move, right? There is this unpleasant sensation, maybe like water running down our calves, or maybe some bugs crawling, and we just need to move. And then we get up, we move around, that goes away, we come back, we sit down, it comes back in a few minutes again. So this is a prototypical description of a restless leg syndrome. Now, interface of RLS and Parkinson's disease is very similar. And I would argue that we don't even know the prevalence of how common is restless legs in Parkinson's patients, because it is really hard sometimes to distinguish what are symptoms of Parkinson's disease and that can really be our RLS mimics. There are many mimics of RLS, and therefore a lot of patients will say, I have RLS, and at the end of the day, it's not going to be the RLS. It's going to be maybe rigidity that gives patients that uncomfortable sensation that is relieved as they get up and walk. It can be nocturnal leg cramps. Some patients will have peripheral neuropathy. So it's really important to think carefully, is this restless legs? Is this something else? And the good news for patients who have both is that we use the same medications that we would use in the treatment of Parkinson's disease to manage restless leg syndrome. So there is a silver lining there, but this is, I'll leave it here so that we have more time maybe for some other questions and answers. I'll leave it here when it comes to restless legs.
Okay, great. Yes, I know people are going to have questions. They're already asking them. And then insomnia.
Insomnia, inability to fall asleep, to stay asleep, or to sleep enough, early morning awakening, right? Or combination of any of these three symptoms. Very common problem in Parkinson's patients. The most common, I would say, and specifically what is common, it's fragmented sleep. I think if we are to address the largest unmet need among patients with Parkinson's disease when it comes to sleep, I think it is really fragmented sleep. Patients will easily fall asleep in majority of cases, but then an hour or after 3 hours, they will wake up, and they're going to fall back to sleep, and this is going to continue throughout the night. And I would say that a lot of our work has really targeted that sleep fragmentation. What can we do to try to consolidate the sleep of our patients? Being the largest problem, in my opinion.
Okay, great. We'll definitely get into that. One of the questions we do get is, people will write to us, talk to us about their sleep issues, and they want to know, when does a, just sort of general sleepiness, fatigue, insomnia, when does that rise to the level of a sleep disorder, and that they should, raise their hand and say, I need some real specific help here?
Well, I would suggest that the patients talk to their loved ones, their caregivers, their spouses, their children. They may learn very valuable information how their sleep is. They also may have a lot of insight to begin with. And if the quality of life is really impaired and affected by their inability to sleep or inability to stay alert, after you ask yourself that question, it's important to start with a self-assessment.
Mhm.
I think it's time to approach a physician or allied health professional and talk about these issues.
Yeah, and could be great to, the minute you start thinking about it, start tracking it, and if you live with somebody, sleep with somebody, have them start tracking it with you so that you can go with a lot more data. Okay, so I would love now to take each one that we talked about and then talk about the different treatments, pharmacological, non-pharmacological, that are working, and certainly I'm sure light therapy will fall into that. So let's talk about daytime sleepiness and sleep attacks. What is typically?
Yeah, so I probably, Mel, what I would say first, it is really important first to get a good understanding before we jump onto treatment, right? Because obviously it is important to diagnose appropriately primary sleep disorders, right? It is important to find out if somebody has sleep apnea, or if somebody has restless leg syndrome, or if somebody has RBD, right? Because these are categories of sleep disorders which are very clearly defined, and we can diagnose them. If you take a look at sleepiness, for example, or sleep fragmentation, you really don't know what's causing those, because apnea, restless legs, and RBD, they can all be causing this sleepiness and nighttime sleep fragmentation, right? So it's really important to take an opportunity and not miss the primary sleep disorder that may be main driver of these issues with sleep and alertness. It's also very important to pay attention about, and this is uniform across all of these sleep problems. That's why I'm mentioning this now. It is important to understand whether one is depressed or not, because that has a huge impact on alertness and ability to sleep at night. And an antidepressant or behavioral therapy to improve mood can be really very helpful in these cases. Similarly, a review of medications, it's also very, very critical, because if someone is taking a lot of sedating medication during the daytime, or if they take medicine that have alerting properties close to their routine bedtime, that's going to make them unable to be awake during the daytime or fall asleep at night, respectively, right? So these are some basic grounding principles that one can try to employ.
So let me speak to that a second. So if you had somebody come to you and they're kind of talking about all these different sleep issues that they're having, might you say, hey, let's get you assessed by a neuropsychologist or psychiatrist or something like that first to see if there's depression? Or is this something that you're going to do an assessment there and then be like, oh, okay.
Yeah, I may do assessment. If I feel that there is untreated depression, I may treat depression. If I feel that they may need a sleep study to see whether they have sleep apnea, we're going to run that test. We're going to get that answer quickly. I may adjust some of their medications and tell them, please do not take amantadine too late in the evening. Mm-hmm. Or you are taking too much of clonazepam during the daytime for the management of anxiety. Can we manage your anxiety in some different way? And if they have sleep attacks, I need to do something with dopamine agonist and tell them we're just going to need to reduce this drug and see how we're going to manage your symptoms of Parkinson's through some other mechanism. It's a really complex conversation that we need to have with our patients. And as you mentioned, in a 30-minute visit, follow-up visit with the provider, there is so much that needs to be discussed. And sleep frequently gets neglected and pushed to the side. And so that's why I'm advocating that our participants today dissect this and think a little bit more carefully about how they approach it.
Right. When you mentioned sleep apnea for a sleep study, what is the value? What can a sleep study tell somebody? What is it not good for? What is it good for?
Yeah, well, the sleep study can tell us what the sleep continuity is. Sleep fragmented. It can tell us what's the oxygen supply during the nighttime, whether what's the breathing pattern. Do we stop breathing every 30 to 60 seconds, which we sometimes see, and that causes a small arousal that we are not even registering, and one can have hundreds of these throughout the night, not realizing they are happening. We can also take at the leg movements and see, are there a lot of leg movements? We can even detect tremors at night as individuals are sleeping. So sleep study is a very useful tool in assessing sleep, and picking up on these diagnoses that we have a specific treatment, like putting a CPAP mask for individuals who have obstructive sleep apnea, which can improve their cognitive functioning during the following day, which can have a positive effects on alertness, overall quality of life, be good for heart health in addition to brain health. So we can do a lot in the sleep arena to improve not only PD-related symptoms, but also to maximize the potential for other problems that can come down the road.
Okay, great. All right, so the marching orders are for everybody to pay attention to their sleep, their patterns, what they're doing, have a friend, a care partner, somebody who lives with you, somebody who spends a lot of time with you to share what they notice, what they see, and talk to their doctor. And let's say, okay, I've gone to my doctor, we've been able to parse out what is what. Let's talk a little bit about some of the strategies that somebody can employ, and then maybe some of the drugs that are being used. And I'd love to talk about melatonin and light therapy, because these are common questions, and people have many questions about what they can do with those.
Sure. So just for the sake of time, if you had a chance to hear Mr. Phinney talk about his approach to sleep, I almost felt, what am I going to talk about after his feedback that he has provided to all of us today? So all of these are great ideas, and I would like to endorse all of them. I am going to touch upon light therapy on melatonin first. Melatonin, we used to call it sleep hormone, right? It is available for purchase over the counter. It is relatively benign substance, medication, however you want to call it. And what it does, it can help with the sleep consolidation. It has a soporific properties, and I think it's a good, relatively benign medication to try if someone has problems with maintaining sleep, assuming that other primary sleep disorders and other causes that can be addressed have already been addressed, right? I think melatonin is a great choice. Melatonin is also a great choice for the management of REM sleep behavior disorder, because it calms out those dreams and this dream enactment. And it's my treatment of choice when I initiate therapy for patients with REM sleep behavior disorder, whether they only have RBD or they have Parkinson's disease and RBD together. We have done a lot of work with light therapy and are currently actually completing a nationwide clinical trial on light therapy and its effect on sleep, fatigue, and some other manifestations of Parkinson's disease. And if you heard me speak about circadian system, I told you that the light is really that connection between our body and our brain and outside world, right? And it is really important that we expose ourselves to enough amount of bright light during the daytime. Why is this important in patients with Parkinson's disease? Well, it is important that Parkinson's patients are prone to not getting enough light during the daytime. And why is that? A lot of Parkinson's patients do not get enough outdoor exposure. There is mobility limitations, there are mood issues, I feel anxious, I don't care, there is apathy, I don't want to go out, you name it. We also said that Parkinson's is a disease of aging. Our eyes are changing as we age. Our lenses that are part of our eyes are becoming yellow. We are developing cataracts. All these are barriers to light getting into our brain. And finally, our retina, which is a part of our eye, on the back of our eye, it's important for our vision, has a lot of dopamine in it normally. But that dopamine gets lost in retina similarly like it gets lost from the brain. And it is that dopamine that is critical for our eyes' ability to process that light from outside world. Therefore, you are hit on so many levels why our brain, if we have Parkinson's patients, is not getting enough light. And therefore, we have, with others groups worldwide, have started to do systematic study of a phototherapy, of a light therapy, in which we provide a supplemental light exposure to our brain, trying to strengthen the function of that clock that is deep in our head and that I said is really directing functions of our body so that we can maximize our health and optimize our behaviors, right? And light therapy is really, it's really like a drug if you think about it, right? You need to know when to do the light therapy, how long to expose yourself to the light. Do you need to do it once a day or twice a day? And also there are all kinds of light, especially in the modern society. Which light is right for me, right? And so it is really not unfortunately, it is not straightforward either. I can't tell you what is going to work for everyone, but I can give you some tips. Do not do bright light very, very early in the morning, or for sure very late at night, because then you're going to shift your normal natural times when your body wants to wake up and when it wants to go to sleep. Sometimes it's a very useful. So someone who, on the other hand, sometimes so we need to time it right. For a person who cannot stay awake past 7 p.m. and would like to go to bed with spouse at 10 p.m., it can make more sense that they do that just before that 7 p.m. mark to push their bed cycle later on. But if someone really normally goes to bed at 10 and starts doing their light at 9:30 or 10, they may not be able to fall asleep until midnight. So we need to be very, very careful. That's why I say, and I like to say, if you expose yourself in the mid-morning, about an hour, 2 hours before you wake up, and if you don't expose yourself to light for about 2 to 3 hours before bedtime, I think you are in a safe zone, right? You want to maximize the bright sun that is out there because that strength of that light is going to be as good, even maybe better than what you can do from the light boxes. And frequently I get a question, how long is enough if I have a light box? I would say if you do it 30 to 40 minutes a day, I think it's a good start. And don't get too fancy with colors. Everybody says, oh, I'm going to have this green, blue spectrum, etc. Just get a good bright light, white bright light, and start with that and see what that can do for you. So I'm going to pause here. So I gave you a lot of tips. I gave you ideas why light is important, gave you idea why you likely are not getting enough light. I gave you idea how to use light. And we'll soon report on this clinical trial and hope to do many more trials based on what we find from this study. And hopefully the light therapy is going to be beneficial not only for sleep. It can improve mood, anxiety. We'll see what effects it may have on a cognitive function. Think about it. It's an easy intervention. It's widely available. It doesn't have side effects for most of the time, as long as you get to used to it and use it properly. Again, you may use light inappropriately. So I just don't want you to start going and buying and ordering on Amazon light boxes today. Just take a time to educate yourself a little bit about it, and maybe we can have a session about light in the future through this type of programming as well.
Oh, I hope so. I have a million more questions, and I just saw the time. So I would love to invite you back so we can have a lot more Q&A around this sleep and light therapy. I do want to ask one quick question though, because I know this is something that people often ask. When it comes, so the light therapy, the timing is important. What about melatonin? Somebody said, do I take it right when I want to go to bed? How is it going to help me with my clock? What is the best time to take that?
Great question. I usually advise patients to take it 30 to 40 minutes before intended bedtime. There are some other applications of giving melatonin, try to help patients who are owls or larks to become a little bit more to the norm, but that's too complicated. For Parkinson's patients who want to take it for poor sleep or to treat RBD, just take it 30 minutes before bedtime. Start with the 3 milligrams. If you cannot find 3 milligram tablets, you can go to 5 milligrams. See what that dose does for you, and then discuss it with your physician, what the next step should be.
Okay. Well, thank you very much. Yes, you have an open invitation to come back whenever. I appreciate everybody's questions. I hope we got to a lot of them. Thank you again so much for being with us.
Thank you for joining us for this episode of the Parkinson's Podcast. For more information about the Davis Phinney Foundation and to learn about educational offerings and community events for people affected by Parkinson's, please visit davisphinneyfoundation.org or dpf.org.